We'll be covering physiological changes in pregnancy, and I'll be trying to cover three most important systems in the body. Now, I understand that all of you are now approaching your exams. So just a word of advice that all of you are preparing so well, okay? But when we are doing the recalls and all, also you are actually missing out on a few words. So what I want to tell you is that, the nervousness that you're all feeling, this is all very natural, and in most cases, it's actually not needed also. You're all so well prepared. Okay, but don't be overtly nervous and don't panic during your exams. So now is the time to just reset yourself and pace yourself. Okay, don't rush through the questions. Avoid what we call as skim reading. Okay, and at the same time, of course, you have to maintain a proper pace so that you don't go too slow. Okay, and keep telling yourself that you're going to do your best, and these exams really don't, judge your capabilities. Just give your best, and that's all that you can do. Okay, so starting our topic for today. Now, during pregnancy, a woman's body undergoes significant changes that affect virtually every organ. And the normal pregnancy, it tries to adapt and support the pregnancy and the development of the growing fetus. The process of adaptation is continuous and dynamic, and it begins right after conception and continues throughout pregnancy. So overall, pregnancy is a hyperdynamic, hypermetabolic, hypervolemic, hypercoagulable, diabetogenic, and a low vascular resistant state. Okay, and most women, like our lady over here, despite going through all these changes, okay, they experience an uncomplicated pregnancy. And with the anatomy and function of the organ systems, they return back to their normal non-pregnant state after delivery with very minimal residual effects. Now, in certain circumstances, however, these changes may unmask or worsen a pre-existing condition or disease. So as clinicians, it is very important for us to, like we are all providing antenatal care, to understand the basic physiology and the adaptations of all the body systems related to pregnancy, and to be able to differentiate from adaptations that are abnormal. And of course, these are very important for answering exam questions as well. So our agenda for today will be to cover the cardiovascular, the respiratory, and the hematological changes in pregnancy, the physiological changes in pregnancy. We will begin with the cardiovascular system, as it is very important, because we know that cardiovascular diseases are the leading cause of direct and overall maternal deaths in the UK. Pregnancy is associated with a lot of anatomical and physiological remodeling of the cardiovascular system. And there is increased circulating blood, both maternal volume, and of course, to add on to that, there is nutritional a placental circulatory system which is added on. So this is all going to increase the cardiovascular load on the heart. Now, like we said earlier, most women, these increased demands are met without compromise. But if there is a pre-existing disease, states may, they may impair the homeostasis of the body, and they can cause a lot of deterioration during pregnancy. Maternal cardiovascular system is also altered during the intrapartum and postpartum period, as we will be discussing. Now, the changes, they start becoming apparent within the first few weeks of pregnancy. And the various parameters that we measure are right in front of you. So heart rate, stroke volume, blood pressure, cardiac output, CVP, the systemic vascular resistance, the blood volume, serum colloid osmotic pressure, and the pulmonary capillary wedge pressure. So as is in the exam, at least for all the systems, what we need to do is know which parameter is going down and which goes up, the levels of which parameter goes up. So before we move on to that, let us revise a few definitions. So what is stroke volume? It is the amount of blood pumped by the heart in one contraction. What is the cardiac output? It is the amount of blood pumped by the heart in a minute. And it is the stroke volume multiplied by the heart rate per minute. That will give you the cardiac output. So now let us see what goes up and what goes down. So I'm going to be demonstrating here. So at home, maybe you can just take a paper and pen and note down what goes right and what goes wrong. So heart rate goes up. The stroke volume goes up. Blood pressure, it falls down. The cardiac output goes up. What happens to the central venous pressure? It stays the same. What happens to the systemic vascular resistance and the peripheral vascular resistance? Both of them decrease. The blood volume goes up. The serum colloid osmotic pressure goes down, and the pulmonary capillary wedge pressure remains the same. So this is just a simple little question, and they can ask you simple questions in the exam. So if Maria has a resting heart rate of 60 beats per minute and a stroke volume of 70 ml, what is her cardiac output? So we've all seen that cardiac output is the stroke volume multiplied by the heart rate per minute. So our answer will be 4.2 liters per minute. Now, the least invasive way to determine stroke volume is by which one of these methods? It is echocardiography. Now, with regard to the cardiac cycle, this is a repeated question. With regard to the cardiac cycle, what is the definition of stroke volume? So you must have already answered. The right answer is B. It is end diastolic volume minus the end systolic volume. So the stroke volume is also calculated by subtracting the end systolic volume from the end diastolic volume. In effect, there is 60 to 70% blood left in the ventricles at the end of diastole. Stroke volume refers to the left ventricle, although it can be applied to both. Both ventricles have an equivalent stroke volume, which in an average size adult is approximately 70 ml, and this increases in pregnancy. Now, changes in heart sounds on auscultation, it can be found in around 90% of pregnant women, and many of these are normal. So there might be a louder and a more widely split first heart sound, which can be noted from the 12th week, and it can continue 2 to 4 weeks postpartum also. This results from an increased flow across the mitral valve. Most women develop pulmonary and tricuspid valve regurgitation, and a third of the pregnant women, so 1/3 pregnant women, develop minor mitral regurgitation also. During the last 10 weeks of gestation, a persistent splitting of aortic and pulmonary elements of the second heart sound is audible, which is also considered a normal adaptation. Third heart sound may be present in up to 90% pregnant women. During the last 2 trimesters of pregnancy, more than 90% women demonstrate a mid-systolic murmur along the left sternal border, which is indicative of increased ejection load of the blood from the right ventricle into the pulmonary trunk, or from the left ventricle into the brachiocephalic arteries. Now, we know that most of the changes that occur in pregnancy, they are due to anatomical and physiological adaptations in response to the various changes that are happening in pregnancy, which include a shift in heart position, changes in the spatial arrangement of the chest organs, and alterations in the electrical properties of the myocardium under the influence of sympathetic and hormonal modulation of the body, that is epinephrine and progesterone mainly. Now, these alterations in anatomical and physiological cardiovascular parameters, they bring about a change in ECG during pregnancy. There is an increased incidence of arrhythmia such as atrial and ventricular ectopics, supraventricular tachycardia. These can happen in increase in pregnancy. Now, the normal ECG findings are an often asked question in the exam. So we should be aware of these. They can ask which of this, they can give you like 5 options and ask you for which is abnormal, or they can give you a normal finding and ask you for which is normal. So we should be aware of these normal ECG findings in pregnancy. Now, the cardiovascular parameters that are altered during pregnancy and that contribute to increase in cardiac output include rise in plasma volume and the total blood volume, increase in stroke volume and heart rate, and a marked fall in systemic vascular resistance, which results in a decrease in the blood pressure also. Now, the cardiac output increases more in labor. Okay, so it is already rising up to 50% of normal, but in labor, in the first stage, it goes up by 15%, and in the second stage, it rises to 50%. This is mainly because of the blood which is expressed from the uterus during each contraction. Following delivery, there is an immediate rise in cardiac output due to the release of pressure on the inferior vena cava and contraction of the uterus that empties the blood into the systemic circulation. So the cardiac output, it will increase around 60% immediately following childbirth, followed by a rapid reduction to pre-labor levels 1 hour postpartum. So again, in normal women, healthy women, they can cope up with these changes, but in women with cardiac compromise, they are at maximum risk of pulmonary edema in the second stage of labor and immediate postpartum period. The cardiac output returns to normal about 2 weeks following delivery. Now let's discuss something which I'm sure all of us are very well aware of, the supine hypotensive syndrome. It's postural hypotension, or also called as Menger's syndrome or inferior vena cava syndrome. This may develop late in pregnancy if the lady is lying in supine position, and it occurs due to compression of the inferior vena cava by the enlarged gravid uterus. So there is decreased venous return and the cardiac output is affected. The low blood pressure, which is caused due to all of this, may cause fainting. This occurs mainly in women, approximately 10% of women, where the collateral circulation between the paravertebral and azygous vein fails to develop, resulting in curtailment of venous return to the heart. And the treatment is by turning the patient to a left lateral position, elevating even the mother's right hip by 10 to 15 centimeter, may also relieve aortocaval compression in up to 58% of term patients. Now, supine hypotension syndrome is particularly dangerous during cesarean deliveries under spinal anesthesia, when sudden severe hypotension can impair oxygenation of the fetus. Fortunately, during normal labor, there is some protection because the uterine contractions, they enhance the venous return to the heart, resulting in increased effective blood volume. So this is a chart that I would advise that all of you have it, on a sticky note in front of you, so that one of the important notes, so that, you can go through them daily. And then when the exam time comes and you're asked these questions, you don't really need to, do a lot of thinking. It will come automatically to you. So moving on to our next topic, which is going to be hematological changes. Now, the physiological adaptation of the hematological system during pregnancy, it is aiming to actually ensure adequate blood supply to the gravid uterus and the baby. And this is done to actually safeguard the mother and baby against blood pressure changes and impaired venous return. There is a need for an increased blood volume, etc., to compensate for blood loss during delivery and also to support fetal hematopoiesis. So to cater to all these requirements, hematological adaptation in pregnancy, this begins as early as 4 to 5 weeks of gestation and includes progressive changes in plasma volume and red blood cells, leukocytes, immunological function, thrombocyte levels, and various coagulation factors. Now, these changes are also mediated by changes in the hormone milieu of pregnancy and puerperium. Now, in a pregnant individual, plasma renin levels, they rise and the atrial natriuretic peptide levels fall. This leads to systemic vasodilatation and increased vascular capacitance. Now, without compensation or without increased blood volume, this would lead to an underfilled vascular system. So to compensate for this and to compensate for the blood loss during delivery, maternal blood volume is increased by approximately 1.5 liters. Now, in addition to this, maternal erythropoietin production is increased, leading to increase in red blood cell mass by approximately 30%. Now, the increase in plasma volume is greater than the increase in RBC mass, and this results in what we call as dilutional or physiological anemia. And now would be a good time to discuss the definition of anemia in pregnancy. Anemia in pregnancy is defined as first trimester hemoglobin less than 110 grams per liter, second and third trimester hemoglobin less than 105 grams per liter, and postpartum hemoglobin less than 100 grams per liter. Now, an increase in RBC mass coupled with an increased blood flow to the uterus, this will lead to optimized oxygen transport to the fetus. However, an increase in RBC mass also means an increase in the physiological demand for iron throughout pregnancy. And approximately 1,000 milligram of iron is needed during pregnancy, 2/3 for the need of the pregnant woman, and 1/3 for the placental fetal tissue growth and needs. Now, we all know that pregnancy has an effect on the coagulation system, and it is a hypercoagulable or a prothrombotic state with increased level of coagulation factors. Now, this can be caused by elevated estrogen levels, which mediate an increase in protein synthesis. Increased estrogen during pregnancy has been implicated in the hypercoagulable state associated with pregnancy. Hypercoagulability occurs with platelet activation also, which includes degranulation, adhesion, and aggregation. And elevated estrogen in pregnancy also influences the red blood cell and platelet morphology. Now, as the pregnancy progresses, clotting factors 7, 8, 10, 12, von Willebrand's factor, and fibrinogen level markedly increase. Now, due to this increase in factor 8, the activated partial thromboplastin time is typically shortened, while the prothrombin time and thrombin time remain unchanged. Now, due to this hypercoagulable state, pregnant individuals are up to 5 times more likely to develop a deep vein thrombosis than their non-pregnant counterparts. And the hypercoagulable state of pregnancy is actually evolved by nature to protect women from excessive bleeding during miscarriage and childbirth. So another question that they often ask is about which levels of which coagulation factors they are going up and which are going down. So my question to you now is level of what clotting factors does not change in pregnancy? So factor 2, 5, 9, they say sometimes it falls or sometimes it stays the same. Protein C and protein S. These are the clotting factors that do not change their levels in pregnancy. So this will be a quick recap, and the answers will be given at the end of my presentation. So these are 5 questions that I would all, like all of you to answer so that we'll know where we stand. Okay, so in pregnancy, plasma volume increases by how much? Blood volume increases by how much? The heart rate increases by how many beats? Cardiac output peaks at how many weeks of gestation? And what are the high-risk periods during pregnancy for cardiac decompensation? Okay, so the answers are right at the end. Moving on to our last chapter for today, which is the respiratory system. Now, in normal pregnancy, there is an increase in oxygen demand. This is due to 15% increase in the metabolic rate and a 20% increase in the oxygen consumption, which leads to the increased oxygen demand. Now, the physiological changes of the respiratory system in pregnancy, they are all aimed at increasing the volume of air and gas exchange in order to increase the oxygen availability and remove carbon dioxide. We'll be seeing that shortly. Now, ventilation increases by approximately 40% owing to the stimulation of the respiratory center by progesterone, both directly and indirectly by increasing the sensitivity of the respiratory center to carbon dioxide. So the various changes related to pregnancy and how they will affect the system will be as follows. So there will be mucosal edema in the upper airway, which actually results in greater resistance to flow, and it can cause more difficulty in bag and valve mask ventilation, and there is a greater risk of airway obstruction with sedation. Now, the anatomical changes which undergo in the respiratory system, the diaphragm is pushed up by 4 centimeter and the diaphragmatic excursion increases by 2 centimeter. The rib cage, it expands, the subcostal angle, it increases from 68.5 degrees in non-pregnant state to around 103.5 degrees in the pregnant state. And this is all due to hormonal changes and mainly due to relaxin. So it relaxes the ligaments of the rib cage, and this allows for rib cage expansion. The anatomical dead space, it increases by 45%. The chest wall compliance decreases. However, the lung compliance remains the same. In the lower airways, the resistance is increased in early pregnancy and it decreases in late pregnancy. The lung volumes, these are very important. I will be shortly discussing the definitions also with you, but we have to know about the tidal volume. The respiratory rate, it remains unchanged. Minute volume, it increases by 40% and is very important as we'll be discussing. The total lung capacity is reduced. The inspiratory capacity is increased and the functional residual capacity is decreased by around 20%. In normal pregnancy, so when they are giving you the acid-base balances also, we need to really remember the PaO2 of a pregnant and a non-pregnant state, although they usually give the values, but we have to know that in pregnancy, the PaCO2, it will be lesser than in non-pregnant state and the PaO2 is higher. Now, the oxygen carrying capacity, this is higher in the maternal erythrocytes as they have higher levels of 2,3-DPG. Okay, so this is a spirometry graph, okay, and you really need to know which phase is representing what, because a question can be asked from any of these phases, okay, and here you can see, the various changes that can happen in pregnancy, and the mnemonic, I think all of you will be remembering, is I see movie in a TV. So this is all the factors that will increase. So inspiratory capacity, the minute volume, the inspiratory reserve volume and tidal volume, they will all increase. And for decreasing, you can have your own very mnemonic, but REFT is pretty, easy to remember. So residual volume, then the expiratory reserve volume, okay, then the functional residual capacity and the total lung capacity. So these are all decreasing, okay. So like I said, all these adaptive respiratory changes that occur, they are actually occurring to make breathing easier for the mother, and they increase the oxygen availability for the benefit of the developing fetus. Now, most significant amongst these changes is the 40% increase in tidal volume by the end of first trimester due to increased oxygen consumption and CO2 production and their exchange across this alveolar membrane. Now, in labor, the increase in oxygen consumption can go up to 100%. Okay. Then there is an increase in minute volume. So how does this happen? First, the progesterone effect on the brainstem. okay, which will send signals to the lungs and increase the rate and depth of respiration. Okay, so because of increased carbon dioxide production and the increase in progesterone, these both will contribute to increased minute volume. Now, this increase in minute volume is actually going to cause a hyperventilatory picture. Okay, and it will result in respiratory alkalosis with metabolic compensation. Okay, so the partial pressure of CO2, it is going to fall. The pH is actually going to rise. Okay, and the normal PCO2 in pregnant patient, if it is a normal PCO2, it will imply that there is an impending respiratory failure. Okay, so the CO2 level, it actually falls. So this is an oxygen hemoglobin dissociation curve. Okay, and in pregnancy, there is a right shift of this curve because of the PCO2 and the 2,3 DPG levels. Okay, this 2,3 DPG level is going to rise and it will decrease the affinity for oxygen in the maternal erythrocytes so that there is availability of this oxygen for the growing fetus. Okay, so this is the oxygen hemoglobin dissociation curve. As you can see in the pregnant lady, it is a rightwards shift. So these are the values that you should all be remembering. Okay, so although in a normal non-pregnant pH is 7.35 to 7.45, in pregnancy the pH is actually towards an alkalotic state. Okay, similarly a normal PaCO2 is 35 to 45, but in a pregnant state it will be 27 to 32. So if they've given you values there, you have to accordingly decide whether this is a normal carbon dioxide level or a abnormal one. And these are the definitions of the various parameters in the spirometry. And I'm sure all of you are aware of them, but please go through them so that you are very sure that you're going on the right track. Now, with regard to spirometry, as I told you, they can ask you, they can give you various blanks and then mark them and then ask you what lung volume is represented by this particular arrow. So here I've given you this spirometry trace and an X is marked. So tell us what is this particular lung volume, this one here. So this is the residual volume. Okay, so this was the questions that I had asked you earlier for recap. So these are your answers, and these conditions of cardiac decompensation, these are very often asked, and you have to remember that the maximum risk is immediately postpartum. Okay. So despite all of this, changes in pregnancy, which can be normal and can go wrong also. Pregnancy is a beautiful phase for all the women. So the smallest things take up most of the room in your heart. And with this, I'd like to end my presentation and wish you all the very best. You're all doing extremely, extremely well. So just carry on whatever you're doing. Just carry on discussing, carry on your studies, and just do well in the exam. All the best. We can end now.